Good morning, everyone. I think we can get started. I think it's my great pleasure to welcome Dr. Nicole Cipriani from University of Chicago. She is currently an associate professor and the medical director of gross pathology and anatomical pathology informatics and head neck pathology. Dr. Cipriani got his undergraduate and a master's degree in University of Chicago and also University of Illinois at Chicago. So she's a native Chicagoan. And then he got his MD in University of Chicago and then did a resident APCP in University of Chicago and did a 1 year of fellowship in Mass General Hospital and then came back to the University of Chicago. She has published extensively in head neck pathology and also bone and the soft tissue, has 79 peer-reviewed papers and multiple book chapters. And she's currently edited a book about frozen section interpretations. And Dr. Cipriani is very active in several professional societies. She is currently served as a treasurer for North American Society of Head and Neck Pathology. She has received many rewards in education, research, and service. Today, she's going to discuss a very interesting topic to me and also sometimes difficult about the thyroid follicular-patterned neoplasm. Welcome.
Thank you. Thank you so much for inviting me. It is my pleasure to speak with you all today about a subject that I am quite passionate about, which is thyroid pathology. So I'm sorry, my computer had a little blip there, but hopefully you can still see my full screen PowerPoint presentation.
Yes. Yes.
Fantastic. Okay. Yes. So thank you again. I hope you all are staying warm in Minnesota. We're trying to stay warm here in Chicago. We have a wind chill of it's like 20 degrees yesterday, but you guys are used to that kind of thing. So yeah, if I'm going to be speaking about diagnostic dilemmas in follicular-patterned thyroid neoplasms, spanning a number of topics. So if you have any questions, please, feel free if you'd like to unmute yourself and ask or type in the chat. I will have my chat open. All right. So without further ado, where have all the cancers gone? I have no financial disclosures. So today we're going to talk about a few things. We're going to evaluate the proposed histologic criteria for NIFT-P and identify some challenges in using these criteria. We're going to discuss more global challenges in the diagnosis of capsular and vascular invasion in various follicular-patterned neoplasms. And we're going to talk about some genetic differences that may aid in evaluation of these well-differentiated thyroid neoplasms. So I like to sort of put things in perspective. So in the 50s, the historical classification of thyroid cancer was based both on histologic features and behavior. So there was histology being papillary, if predominantly papillary morphology, metastasizing mostly to lymph nodes, follicular, if invasive and predominantly growing in follicles, Herthel, which was an oncocytic generally variant of follicular. And interestingly, there was a mixed carcinoma, which was invasive and demonstrating a mixture of papillae and follicles. But what is common to all of these is the presence of invasion, which we will see has morphed over time. There was also behavioral classifications, group 1, group 2, group 3, which basically corresponds to our current day well-diff, poorly diff, and undiff or anaplastic thyroid carcinomas. So the follicular variant of papillary came up in the 60s and 70s, both by Stuart Lindsay, as well as published by Rosai, describing this series of invasive neoplasms that had classic papillary/ground glass nuclei and behaved like papillary carcinoma, but grew in follicles. And interestingly, from the 1970s paper, they said morphologically, this variant resembled papillary in all regards, except for the absence of papillae, and its biologic behavior also resembled papillary with a high incidence of regional lymph node metastasis, lack of distant metastasis, and a relatively good prognosis. So Keep this in mind as we go through the metamorphosis, let's say, of NIFT-P. So papillary thyroid carcinoma follicular variant. At some point, we have encapsulated tumors growing in follicles, some that had capsular invasion, some that had vascular invasion, all with PTC-like nuclei, some that were not invasive at all. Some of these were thought to metastasize to lung and bone. Therefore, there was a fear, right? And so nuclear features took precedence over architectural features and behavior. So then any tumor growing in follicles that was either encapsulated or invasive with papillary-like nuclei was then called papillary carcinoma follicular variant. We have two subvariants then of papillary carcinoma follicular variant. So getting into the weeds a little bit, the infiltrative follicular variant of papillary, which was very much like the original description, sclerosing invasion, lots of follicles, maybe a few abortive papillae, and the circumscribed follicular variant of papillary carcinoma, some of which had capsular and vascular invasion, all of which had follicles, and certainly atypical ground glass, orphan Annie, wrinkled, cleared nuclei. Okay. So finally, the bottom line comes down to April 2016, where it was published this proposal for renaming the non-invasive, well-circumscribed follicular variant of papillary thyroid carcinoma if certain criteria were met. I'm sure many of you are well acquainted with this paper that had mostly pathologists, but also some clinical faculty, as well as even patient, for sort of psychological, psychiatric sort of issues, changing diagnoses from cancer to benign and vice versa. All of their images are published and you can go view them here if you'd like. The bottom line was proposing a diagnosis change from encapsulated follicular variant of PTC to non-invasive follicular thyroid neoplasm with papillary-like nuclear features, NIFT-P, if certain criteria are met. What are those criteria? Basically, certainly encapsulation or at least clear demarcation, follicular growth pattern with less than 1% papillae, no Somoma bodies, less than 30% trabecular growth, a nuclear score of quote unquote 2 to 3, which means, your nuclear changes have to be essentially sufficiently expressed in both quantity and quality in order to push you into this category. They can't be sort of focal and minimal. Otherwise, it's just a benign adenoma. Certainly no vascular or capsular invasion, no necrosis, no high mitotic activity, adequate microscopic examination of the capsule. 2 years later, in 2018, these criteria were revised. So from less than 1%, we went to 0, no papillae allowed. We caveated nuclear score 2 to 3, which was typically most NIFT-Ps have an intermediate nuclear score with moderately expressed features. If you see a quote unquote nuclear score of 3 or very robust papillary-like nuclei, you may want to submit the entire tumor to exclude the presence of papillae. You should examine the entire tumor capsule, or I'll say tumor periphery interface. And secondary characteristics where you should not have any BRAF mutation, specifically no BRAF V600E, either by IHC or molecular sequencing. In addition, no high-risk TERT promoter or TP53 mutations. These are mutations that are thought to confer a more aggressive phenotype on thyroid neoplasms. Okay, so hopefully that's all coming a little bit clearer. So this proposed terminology was based both on genetics and morphology and behavior. So we have this sort of schematic of BRAF-driven tumors that tend to be papillary, whether they are microcarcinomas or overt, conventional PTCs. We tend to have the RAS-driven tumors that are conventional follicular, either adenomas or follicular carcinomas. And we now have this new group of follicular-patterned neoplasms with papillary nuclei, but mostly end up being driven by RAS, formerly the non-invasive encapsulated follicular variant of PTC. If it invades, it would be the encapsulated follicular variant of PTC. And it's this non-invasive EFV PTC that is now NIFT-P. Okay, so hopefully that clarifies concepts. We're going to repeat this over and over and over again. All right, what you'll notice is that papillary nuclear features are kind of on both sides of this spectrum. Ultimately, why does a diagnosis of NIFT-P matter? So previously, follicular variant of PTC diagnosis may have prompted completion thyroidectomy plus or minus radioactive iodine administration, depending on the size of the tumor, the clinician, and the patient preferences. However, a diagnosis of NIFT-P on lobectomy does not require further treatment. No completion, no radioactive iodine, just close observation, because these tumors are extremely, extremely indolent behaving. So let's take a closer look at all sort of thyroid neoplasms in general. So remember, follicular variant, infiltrative type, generally has BRAF V600E mutation, lymph node mets. The circumscribed or encapsulated variant generally was RAS-driven and had hematogenous potential metastases more often than lymph node mets. We have classic PTC, which starts to look very similar to infiltrative follicular variant. We have the follicular neoplasms, on the other hand, which we know well as adenomas and carcinomas, being predominantly RAS-like. When this proposal happens, what changes is the infiltrative follicular variant of PTC sort of starts to cluster over here with classic, and NIFT-P starts to cluster over here with the follicular neoplasms. If something that would otherwise be diagnosed as a NIFT-P demonstrates capsular or vascular invasion, it still remains to be called the invasive encapsulated follicular variant of papillary thyroid carcinoma, which I think is a mouthful, but here's where we are. Of course, you can draw sort of a line using behavior and genetics with atypical nuclei that, again, live on both sides of this line. I've highlighted for you, as you can see, the genetics as well as the behavior of generally hematogenous metastases, RAS-driven, versus generally lymphatic metastases, BRAF V600E driven. Interestingly, all of these distinctions, which have been recapitulated in numerous papers, have been supported by the molecular results from the large TCGA study, in which about 500 papillary thyroid carcinomas were sequenced, both their point mutations as well as their sort of fusions and their background micro messenger RNA genetic profiles. These were sorted into two distinct groups. Those that were BRAF V600E like, that very much in their genomics resembled classic PTC. This included true BRAF V600E mutations, interestingly BRAF fusions, as well as RET PTC rearrangements. The RAS-like tumors more resembled follicular neoplasms, follicular adenomas, follicular carcinomas. This was other BRAF mutations like BRAF K601E being one of the most common ones, HN or KRAS certainly being the most common mutation, and PPAR gamma fusions. So these quote unquote papillary carcinomas really sorted differently into the BRAF V600E like and the RAS like. And it's the RAS like group that ended up becoming this NIFT-P category, yeah? So we in U of C critically examined these histologic NIFT-P criteria. We gathered 37 papillary carcinoma follicular variants, 13, we'll call them classic papillary thyroid carcinomas that just happen to have a lot of follicular growth. So we're gonna call them here EFGs, and just 11 benign adenomas. We reviewed them all and did sequencing. And so here's how they sorted. So you can see that the 11 follicular adenomas all remained adenomas on re-review, but the follicular variants of PTC and the extensive follicular growth PTCs sort of mapped differently. Many of them became NIFT-Ps, so we ended up with 32 NIFT-Ps. We ended up with 4 invasive encapsulated follicular variants of papillary, meaning otherwise it would be a NIFT-P, but it had invasion. And then 14 extensive follicular growth papillaries that had sclerosing invasion, maybe a couple abortive papillae here and there. And interestingly, the genetics were very clean. So RAS mutations were predominantly found in the NIFT-Ps, in the follicular adenomas, and in the invasive encapsulated follicular variants of PTC. And BRAF V600E mutations were found in the quote unquote extensive follicular growth PTCs. And these were mutually exclusive, right? We didn't find overlap in the genetics. We found 0 recurrence in metastasis in the NIFT-Ps and in the adenomas, some hematogenous visceral mets in the IE-PTC FVs, and lymph node mets in the, as you would expect, extensive follicular growths. And you can see here how the nuclei and the morphology change across that spectrum. So, cool, this sounds sort of simple enough. We are now able to render a non-malignant diagnosis of NIFP, spare the patient additional surgery, radioactive iodine, perhaps some psychological anxiety to not receive a cancer diagnosis. But within this proposal are certainly challenges, as with any new concept, right? Whether it be in pathology, in art, there's always some resistance when something new happens. So I'm going to examine a lot of these features, and please, again, pipe up if you have any comments or questions. So my first question is, well, what do we do with this mouthful, invasive encapsulated follicular variant of papillary? We have seen that these are essentially RAS-driven tumors. These tend to have hematogenic metastases that resemble very much follicular carcinomas instead of papillary carcinomas, yet the proposal continues to call them papillary, certainly because of their nuclear features. Well, one possible solution between this category of encapsulated invasive follicular variant of PTC is to maybe regard it as almost a follicular carcinoma with atypical nuclei, because it's much more genetically and behaviorally similar. This terminology has actually been published and proposed by some authors to definitely help clarify the biology. The terminology is certainly not accepted by the WHO or by many pathologists, but sort of in a thought experiment, it most often sort of works biologically for these tumors. So just keep this in the back of your mind as a biologic descriptor of invasive encapsulated follicular variant of PTC, perhaps as biologically follicular carcinoma with nuclear atypia. Now, what do we do with the PTC follicular variant infiltrative that we know has lymph node metastases, BRAF mutations? Well, the infiltrative follicular variant of PTC unfortunately doesn't all look alike. So if you're lucky, you'll have this. Like we saw earlier, some sclerosing invasion, mostly follicles, maybe a few papillae, probably Somoma bodies, as you can see here, definitely intranuclear pseudo-inclusions, definitely invasion into surrounding parenchyma. Cool, that's infiltrative follicular variant of PTC. What about if it's not so obvious? And so here I'd like to show you some virtual slides. Hopefully it won't take too long. We can go through them quickly. This was a 31-year-old female with a circumscribed, very well circumscribed, red-brown, 2.8 centimeter nodule. So if I can share instead there we go. Can you see the virtual slide here?
Yes.
Great. Awesome. Thank you. So this is a case of, as you can see, an extremely well circumscribed tumor. There was really no capsular or vascular invasion. You can see that it grows predominantly in follicles. And you can certainly see that the nuclei have clearing, have these wrinkles or cup shapes. They have grooves, very atypical nuclei, but on at least first glance, one was not able to demonstrate invasion or really perhaps any significant papillae. Well, one thing we can do is submit more sections. And the second thing we can do is perhaps do a BRAF immunostain. So BRAF immunostain, which we have in our lab, we're very lucky. I like it a lot. I think it's an excellent stain if used cautiously. So I'm just going to show you the normal background parenchyma for negative control. And then I'm going to move over into the tumor. And so BRAF is a cytoplasmic signal transduction protein. You should see expression in the cytoplasm. And in this case, it's weak, but it's present diffusely throughout this tumor, and it's completely absent in the background parenchyma. So I would regard this as a positive BRAF immunostain. When we submit the remainder of the tumor, it's still extremely well circumscribed, but you'll notice in one corner, you start to show more well-developed papillae with more robust papillary nuclei, including grooves and clearing, etc. And so we regarded this as some kind of papillary carcinoma. Hopefully you all agree. If you disagree, type your reasons in the comments. So I'm going to go back to the PowerPoint and say, in our study, this tumor both had BRAF positivity by IHC, as well as BRAF V600E mutation by next-gen sequencing. This is one of the reasons why I really trust the BRAF IHC, because in our validation study, weak, moderate, and strong cytoplasmic reactivity, if it was diffuse, was really highly predictive of a V600E mutation by sequencing. So I really trust this immunostain. However, this tumor, what are we going to call it? Which variant? Is it the classic infiltrative sclerosing follicular variant? Is it invasive encapsulated follicular variant? Well, it's not really encapsulated, and there was no capsular or vascular invasion. So calling it non-invasive encapsulated follicular variant of PTC may give a false impression of its indolence. It did have BRAF, it did have one lymph node metastasis. So this is one of the reasons why I no longer actually use the term follicular variant. I use a descriptor. I would call this a papillary thyroid carcinoma with extensive follicular growth. Some of my colleagues use the term prominent follicular architecture because in the past, follicular variant included NIFT-Ps, true papillary carcinomas, even things that resembled follicular carcinomas, right? So I'm trying to get away from this wastebasket term of follicular variant and really using descriptors. This is me, right? This is not, WHO. This is me and a few other colleagues who believe in this sort of, morphologic biologic correlation. So one of my possible solutions is to get rid of infiltrative follicular variant of PTC, and again, call these PTCs with extensive or abundant or prominent follicular growth. Okay. The next question that I have is what to do with circumscribed nodules that may have some papillae. So we know that papillae or papillary-like structures can be seen in totally benign, totally hyperplastic nodules with bland nuclei. Yes? Yes. So how do we approach papillae in NIFT-P? Is it quantitatively, meaning either less than 1% or 0%? Is it qualitatively based on morphology, or is it both? So this is another case example of a 38-year-old female with a circumscribed 2.5 centimeter nodule. I'm going to show another virtual slide. So this is the case here. You can see the nodule is composed of anywhere ranging from very small follicles to very large macro follicles. I apologize for the disruption here, but you can see that it's generally well circumscribed. At the edge, there's a rim of inflamed but non-lesional thyroid. But when you look in the center of this lesion, you will perhaps notice that there is very complex architecture. Yes, you can make out follicles, but you can also make out these, papillary-like structures. In some cases, the papillary-like structures have very thick fibrovascular cores with a lot of fibrous stroma in between. And in other areas, you may make out that some of the papillary some of these papillary structures that project into the lumina of follicles actually have other follicles within the core of the papillum. So is this a real papillum? What is it? So these are very challenging cases, but you'll notice that the nuclei are not bland, right? They're not very round, very regular, very dark chromatin. They are somewhat enlarged and elongated and have open chromatin and overlapping, right? So what do? So I'm going to go back to PowerPoint. Okay. So what's our diagnosis? Is it, if we regard these as true papillae, this case would be excluded from the diagnosis of NIFT-P and should be called classic PTC or PTC with, follicular growth. If we regard these as not true papillae, this could be a NIFT-P. So we're between a malignant and a potentially non-malignant diagnosis. So some papers have defined true papillae as complex, arborizing, with fibrovascular cores, I would argue thin fibrovascular cores, lined by cells with nuclear features of PTC not associated with an FNA area. Well, arguably, the papillae in this case may be just large geographic infoldings of dilated follicles with very thick fibrous cores and really non-branching. So maybe not true papillae. What else might help? Well, this was part of our project. we did sequencing, and this had a KRAS G12V mutation. So not a BRAF V600E, but one of the known RAS follicular-like drivers. So is this NIFT-P with hyperplastic type of papillae? So I do think that molecular testing could be useful in equivocal cases where we know that BRAF V600E is considered exclusionary of NIFT-P, but I believe that RAS mutation may also be supportive of NIFT-P and exclusionary of a classic PTC. So unfortunately, the NIFT-P criteria do not discuss the significance of RAS mutation, but this is what I have developed in my sign-out practice over time. So give this some thought. We can certainly talk about it. This is an example of where I put this into practice. So this is a 44-year-old with bilateral lesions. She has a 1.5 centimeter tumor on the right lobe, which was PTC on FNA. She has a 5 centimeter tumor in the left lobe, which was benign on FNA. You can see the gross differences. And I'm going to show you a couple virtual slides again. I'll try to do this quickly again. All right. So I need there we go. All right. So this is the smaller, pretty obvious conventional PTC with sclerosis, with well-developed papillae, with great nuclear features. No one's going to argue this. The larger tumor on the contralateral lobe is very well circumscribed, mostly follicles. And when we evaluate the nuclei of these follicles, we again see that they're enlarged with clearing and grooves and overlapping. So, all right, what are we going to do? Is this another PTC? Well, in this case, we again considered sequencing. So the thought process would be if both of these lesions are papillary carcinoma, based on size, these would be PT3, okay? If only the smaller is PTC, this would be PT1. So a very significant stage difference. BRAF V600E was found in the conventional tumor on the left, and NRAS Q61R was found in the atypical tumor on the right. So I actually felt very comfortable calling the one on the right PTC, the one on the right NIFT-P and the one on the left PTC. So this person was a low stage PT1BN0. So would not require radioactive iodine necessarily, but would require close observation rather than potentially, additional ancillary treatment if you had a 5 centimeter PTC, okay? So hopefully this is a little nice clinical example of how I feel like this is an important distinction. We do not, in our institution, have the RAS immunostain, but it's thought that the NRAS Q61R stain will demonstrate both the NRAS Q61R mutation as well as potentially other RAS Q61R mutations, so HRAS and KRAS. This is yet, I think, to be developed in many labs, but it's out there. I would love to start using it, but we don't have it validated currently. So I have no experience with it yet, which is why for these cases, we go straight to sequencing. Okay. My next, any questions or comments so far? I mean, I know I'm going rapidly through some of these criteria. Okay. Somoma bodies. So what if you see Somoma bodies? This is a little bit of a fun topic. Not all calcifications are created equal. So, true Somoma bodies are concentrically lamellated, are present in the stroma or the papillary sort of core, and are thought to be calcifications of infarcted papillae. Interestingly, you can have these concentrically lamellated calcifications in the lumina of thyroid follicles, often oncocytic neoplasms that are thought to be calcifications of colloid. So I would argue when you see concentrically lamellated calcifications, look very carefully at the background. Are you in the stroma? Are you in a papillum? Or are you in colloid? And so these intraluminal somatoid calcifications are more common than we may think. And these on the left really should not be considered evidence of papillary carcinoma. Just a little bit of an aside. Now, what do we do with pseudo-inclusions? Also thought to be pretty diagnostically specific for PTC, but really are allowed in the NIFT-P proposal. So should pseudo-inclusions be allowed? Well, you really have to evaluate pseudo-inclusions very carefully. True intranuclear cytoplasmic pseudo-inclusions which are essentially, right, invaginations or intussusceptions of the cytoplasm into the nucleus that we cut through, should have an outer nuclear membrane, chromatin. The true pseudo-inclusion should have its own nuclear membrane, right? So that thick border, and then a center that resembles the same color and texture as the external and surrounding cytoplasm, because of course it is cytoplasm, right? So all these three to me are true pseudo-inclusions. They're generally one per nucleus, and they're present in occasional, but not all cells. Pseudo-pseudo-inclusions, this is a thing. This term was written about in numerous, well, at least 2 papers. Pseudo-pseudo-inclusions are degenerative or artifactual vacuoles. They do not have a good border. It's sort of fuzzy because there is no actual nuclear membrane. The center is either clear or bluish because there is neither chromatin nor cytoplasm. They are potentially multiple per nucleus. You can see here, this one has 3. And they tend to be in many, many, many cells. And this is thought to be an artifact of processing, not a real biologic process. Well, it could be a biologic process if you're in an area of like FNA or an infarct, but if you're not, it may just be a processing artifact. So this is the same thyroid tumor where the block was processed as an outside institution. This is the consulting H&E stain we received. We got the block, we recut it and restained it at our institution, and those nuclear vacuoles essentially disappeared. So this tumor went from a NIFT-P or possibly a PTC to basically a benign adenoma just based on a different staining protocol. So, I would argue be very cautious about what you think might be inclusions, and really have high criteria. So in our case series, over 90% of classic PTCs had true pseudo-inclusions, and a significant number of NIFT-Ps had these so-called pseudo-pseudo-inclusions. Interestingly, this was kind of an artifact we picked up for reasons that are unknown, but we found that true pseudo-inclusions had strong ubiquitin staining in the cytoplasm in the inclusion. So you can see here's the inclusion, right? And here's a strong ubiquitin staining. In pseudo-inclusions, the potential area in the nucleus was actually pale or devoid of ubiquitin staining. So here's an example of a classic BRAF PTC versus a RAS mutated NIFT-P. So we've thought that the ubiquitin finding was interesting. We're not really entirely sure why. Maybe there's some cytoskeletal localization of ubiquitinating proteins, making it, heavy and dropping into the nucleus, and that's where you get the collection and the staining. But again, sort of an incidental finding, but we've also used ubiquitin in cases where we're not sure if it's a true or a false pseudo-inclusion. So again, I think strict definitions for pseudo-inclusions should be used. If you do see what you think are true pseudo-inclusions, you may want to submit more tumor, really search for other features of true PTC, maybe do a BRAF immunostain so that you can potentially exclude this from being a NIFT-P. Okay, so we're about, half 8:30 through. Are we there yet? Nope, sorry. So we're going to transition now to some challenges that are common to all follicular-patterned thyroid neoplasms. So we're going to shift away from the specific papillary problems to the more general problems of when you're dealing with a follicular-patterned NIFT-P, how do you make a diagnosis of carcinoma? Similarly, when you're dealing with a follicular-patterned adenoma, how do you make a diagnosis of carcinoma? And some common features that might start to worry you might be solid or trabecular growth, might be mitoses or necrosis, invasion of the capsule, or invasion into vessels. So before I continue, again, does anybody have any questions or comments? Okay, so my first question is, what are we going to do with trabecular or insular or solid growth? I regard these all as essentially equivalent because they all qualify similarly in our diagnostic criteria. So NIFT-P says less than 30% solid trabecular growth. So who has seen trabecular growth in a completely benign follicular adenoma without nuclear atypia? I hope many of you have. So this is a 31-year-old female with a very well circumscribed 3.5 centimeter nodule. And these are photographs from areas within the same exact nodule. We have follicles with completely bland nuclei that one would be happy calling a follicular adenoma. We have some areas of trabeculae also with bland nuclei that one might also say, okay, this is a little bit of an area in a follicular adenoma that's got a little bit of, trabeculated growth. No invasion, right? Let's repeat, no invasion. Now we start to see follicles that have nuclear clearing. Ooh, well, is this going to start to make us think about a NIFT-P? In other areas, we have trabeculae with elongated, grooved, and cleared nuclei. Ooh, do we now make a diagnosis of PTC in this nodule? What do we do? So is this an adenoma with focal nuclear atypia and trabecular growth? If the trabecular growth is less than 30%, we might still be in a NIFT-P category. If the trabecular growth is more than 30%, is this now PTC with follicular and trabecular growth? Well, what do we do? So, one might argue to consider expansion of a diagnosis of a potential NIFT-P to consider higher percentages of trabecular or solid growth, of course, pending the absence of invasion and other features. So I would argue we refrain from the diagnosis of carcinoma in the absence of invasion. And there was this one recent paper potentially arguing for an expansion in the criteria of NIFT-P, showing these follicular nodules that had solid growth or trabecular growth, as you can see here, and longitudinal nuclear grooves or features of PTC, right? Grooving, clearing, etc. And they said these had a prevalence of RAS as well as BRAF K601E mutations. You may remember BRAF K601E being a RAS-like mutation. These had indolent behavior on follow-up and may represent a process, let's say, akin to something such as a solid or trabecular variant in NIFT-P. So this is already in the thought, the thought bubbles of some pathologists out there. Maybe the 30% criteria is a little too low. And where did it come from? There are no good controlled studies on percentage of solid or trabecular growth. And 30% was a number that was derived rather than a number that was, validated. So who knows? Who knows where we'll be in the future? I'll leave it at that. So now let's move on to other high-grade features like necrosis or mitoses. So what is the significance of mitoses in a follicular neoplasm? We're going to look at this Venn diagram. So mitoses alone in a follicular neoplasm without invasion, without solid growth, may still be an adenoma, maybe an atypical adenoma. What if you have solid growth alone without mitoses and invasion, also atypical adenoma? If you have both together without invasion, you're probably still at an atypical adenoma. Certainly once you have invasion, you're at follicular carcinoma in any regard. Once you have invasion plus mitoses plus solid growth, then you might actually be at poorly differentiated carcinoma. So only when you have all three features combined do you basically bump yourself up to something that's much more aggressive. So there are a number of papers out there regarding mitotic activity in non-invasive or encapsulated follicular lesions as basically still indolent behaving tumors, benign fashion, advocate labeling it as a follicular adenoma. So these are in bland tumors. So if you're still dealing with a non-invasive follicular neoplasm, should the presence of nuclear atypia render this concept void? So in my thought experiment, I have 3 non-invasive follicular neoplasms without nuclear atypia, right? One of them is follicles, no mitoses, adenoma. The other is follicles plus mitoses, adenoma. The other is maybe starting to be trabecular with mitoses, non-invasive, maybe an adenoma or an atypical adenoma, okay? All benign. But if you had nuclear atypia in this same cohort, well, one of them would be a NIFT-P, one of them that had mitoses would be a PTC, and one of them that had trabecular growth and mitoses would also be a PTC. So now we're at 2/3 malignant. So, oops, sorry about that. This is an interesting concept that I think, has not been resolved, but I would argue to consider mitoses perhaps with a little bit of a caution. Okay. Next, let's think about necrosis. So how to diagnose and deal with tumor necrosis. So on the left is FNA related necrosis that is sort of grungy with cholesterol clefts, with some peripheral giant cells and histiocytes and hemosiderin. Arguably, this is FNA related necrosis that is not intrinsic tumor necrosis. We can regard this as essentially irrelevant. However, once you start to see small or punctate areas of ghost tumor cells without other evidence of fibrosis, hemosiderin, etc., surrounded by completely viable tumor, you might want to regard this as true biologically relevant tumor necrosis. However, in some additional studies, non-invasive tumors with necrosis, many of these did not recur after extensive follow-up, even in the presence of tumor necrosis. So we may consider regarding benign tumors with necrosis as long as they are uninvasive. In our study, we looked at various parameters, including necrosis, TERT promoter mutation, invasion, etc. So we found that necrosis actually correlated with the presence of TERT promoter mutations, both in invasive and non-invasive neoplasms. Once you had invasion and a necrosis and a TERT promoter, then you were really at risk of distant metastasis. The question is really in the cases that are non-invasive, that have necrosis and TERT promoter mutations. These are very few, they're very unusual, and they can be scary. But again, I would argue that in the absence of invasion, it's very hard to call something carcinoma, but the presence of necrosis or TERT promoter might just make one cautious regarding clinical follow-up and submission of the entire tumor periphery to search for potential invasion, right? Because once you see invasion, then you're at a diagnosis of carcinoma and treatment clinically may change, okay? So I would just argue caution with necrosis as well as what I think is a similar TERT promoter mutation, okay? So potentially based on our study as well as other studies out there in the literature, the presence of increased mitoses or necrosis alone may not be diagnostic of malignancy. However, should exert some caution in your comment, may be relevant in the context of solid growth, may be relevant with TERT promoter mutation. But again, these are topics that are not really well defined. These tumors are very rare and still require some long-term follow-up. Okay. Next, how do we deal with, everyone's favorite controversial topic, capsular and vascular invasion? So I would like to introduce here the concept of equivocal, or the trash bag, the dump. So this is adapted from the WHO. These are diagnostic terms that are currently approved and allowed in our repertoire. So we know that NIFT-P is an equivocal diagnosis when nuclear features of PTC are present, but really other invasive features are absent. So NIFT-P is an equivocal category, right? It's a neoplasm, not an adenoma, not a carcinoma. Well, we also have these dumps or TUMPs, which are when either nuclear features of PTC or capsular or vascular invasion are questionably but not fully present. So well-differentiated tumor of uncertain malignant potential or follicular tumor of uncertain malignant potential. These are all allowed in the absence of clear capsular invasion or vascular invasion, right? And so all of these cases are allowed, I'm just going to call it, are allowed to be dumped, right? So what does this mean? All of these cases could be treated with only lobectomy and observation alone, without completion, without radioactive iodine, right? Just like a follicular adenoma. So I'm a believer that, we in endocrine pathology really try to force things into benign and malignant because our clinicians like it and they feel uncertain about what to do with these equivocal categories. But really, when we think about other organ systems, uterus has stumps, right? we don't embrace the stumps, but I think maybe we should start. As long as we have very good relationships and conversations with our clinicians about how these patients should be managed, they can really all be managed conservatively with close observation. So then, what about when you do have capsular or vascular invasion? How does that matter? Okay, so in a conventional papillary thyroid carcinoma, right, with nuclear features of PTC and invasion, these patients may be treated with completion thyroidectomy, radioactive iodine, depending on the risk stratification. If you are dealing with a follicular or a Hürthle cell carcinoma, these may be treated differently if they have capsular invasion only, which are regarded as quote unquote minimally invasive follicular/Hürthle cell carcinomas, and those with any angioinvasion, even one vessel, which may be regarded as now angioinvasive. So in prior systems, up to 4 sites of vascular invasion was allowed to be called angioinvasive, but currently it's 1, right? So you got a single focus of angioinvasion. You're now no longer minimally invasive. You are angioinvasive, and you are regarded as potentially aggressive tumor. So how do we diagnose capsular and vascular invasion? We understand the clinical significance of capsular invasion only being potentially indolent and minimally invasive, and any angioinvasion being potentially aggressive. We like to think about true transcapsular invasion as a characteristic mushroom. And when you see this, boy, you've lucked out because you're done, right? But it's not always this simple. And when you see a nice tumor plug with a nice thrombus and endothelialization, great, you're done. That's vascular invasion. But we see a lot of like artifacts or pseudo-invasive processes. And so I would regard, pseudo-capsular invasion as lesions that have an incomplete or an irregular capsule, as thick septation fibrosis that may be related to biopsy. Even this, what I like to call so-called trickling growth into the capsule that is not fully transcapsular, as perhaps not true capsular invasion. When you see true capsular invasion, you should have a complete breach of that capsule or sort of a nodule of tumor on the other side of the capsule. And if you look at the College of American Pathologists protocols, these are very nicely demonstrated graphically. So anything that's sort of, these little trickles within the capsule, these should not be regarded as true invasion. It really has to be on the other side, right? It could be on the other side with recapsulization of the tip, but really it should be all the way through, not 50%. All right, so I like to use this diagram, and I like to use a lot of deeper levels when evaluating these to really determine if there's capsular invasion. The good thing is, if it's only capsular invasion, it's still minimally invasive and it's still a potentially indolent tumor. Now, vascular invasion, we see a lot of tumor, a cell, I like to say undermining of endothelial cells, especially in Hürthle cell or follicular neoplasms that we know are already very vascular. When these tumor cells start to undermine the endothelium and sort of pooch up into the vessel, is that truly breach into the lumen? Not really. I don't think that there's breach into the lumen unless you start to see some biologic evidence. So that should be endothelialization, that would be thrombus formation, that would be fibrous adherence to the vascular wall. These large plugs, right, that have this fibrous adherence to the vascular wall, these I would regard as true angioinvasion. Again, the CAP has a very nice diagram of detached fragmented tumor cells floating in a vessel. That could just be surgical pathology, friability artifact. Endothelial undermining certainly would not be considered invasion. But once you have endothelial wrapping with fibrosis or thrombosis, these would all be potentially regarded as angioinvasive. So again, very strict criteria for considering something angioinvasive. And when these strict criteria are used, it's these cases that are thought to be biologically important and have the potential for visceral metastasis, okay? So remember, if you have any angioinvasion, this is now an angioinvasive carcinoma, that may require completion and radioactive iodine therapy. If you have a minimally invasive carcinoma with capsular invasion only, you are at potentially observation. If you have a dump, right, one of these equivocal tumors, you're still at observation. And if you have an adenoma, you're still at observation. So again, all of these cases lined in purple could be treated with lobectomy and observation alone, which is why I'm very respectful of angioinvasion. And I like to sort of make sure that it's not there before putting it into one of these categories below. Okay, we have started to occasionally use a platelet marker, CD61 immunostain, in cases of equivocal vascular invasion. And so certainly you can use a CD31, right, to demonstrate that there is an endothelial lining, but we've also started supplementing CD61, which is a megakaryocyte and platelet marker, to identify platelet fibrin thrombi, because we don't have a really good fibrin stain, right? But along with fibrin always comes platelets. So we've started to use clumps of adherent platelets in a vessel around tumor to really help us diagnose true angioinvasion. Okay, so hopefully we've had some sort of key points that we've taken away for your consideration. I will provide a summary in a minute, but the other things I would like us, a couple quick points I'd like us to consider are, what are the areas for expansion in these follicular neoplasms in NIFT-Ps? So we've already discussed the questionable, 30% solid trabecular growth in NIFT-P. But what do we do with oncocytic small or large cases? So there's papers on all of these. So small, sub-centimeter NIFT-Ps have also been shown to be essentially biologically identical, indolent, no recurrences. So maybe we're going to expand NIFT-P to lesions that are less than a centimeter because these were not originally included in the proposal. Similarly, large tumors that were greater than 4 centimeters also have been shown to be behaviorally indolent with no recurrences over time. So maybe we can also expand our diagnosis to macroscopically large NIFT-Ps, all right? So small, large, trabecular, maybe even oncocytic. So again, all of these things were excluded from the original description, but now people are starting to look at them and say, hey, like maybe really we can start expanding the diagnosis because these are all showing genetics, behaviors, meaning no recurrence, right? Just like NIFT-Ps. So perhaps we'll see some definitional changes in the future, but I think the push towards not calling, things carcinoma that don't need to is generally good to spare the patient additional treatment, to spare them some psychological anxiety. And so the key features I would like to recap for NIFT-P are clear demarcation without invasion, no papillae, and no BRAF V600E mutation. In my opinion, the presence of a RAS mutation would also be supportive of a NIFT-P. So in summary, we've seen that many carcinomas can be sorted into these BRAF V600E-like compared to the RAS-like follicular neoplasms. We do have the option to equivocate either with a NIFT-P in the presence of nuclear features or with one of these dump categories in the presence of irregular capsular or vascular invasion. All of these can be treated conservatively. I do have a lot of respect, however, for necrosis, true tumor necrosis, and TERT promoter mutations, as this should stimulate some extensive histologic evaluation for invasion and very close, clinical treatment or observation. Certainly, the presence of true angioinvasion may trigger more aggressive therapy, whereas the presence of capsular invasion alone may not. All right. So I hope that was helpful. I know I went through a lot, but I'm happy to take any questions or comments in the last few minutes if you have them.
Yeah, this is a very fascinating talk. I really appreciate your presenting as a visual biomedical artist. This is really, really impressive. So
thank you.
Yeah. So anyone have questions? I can ask first. So like a minimal invasive, we should not use the AJCC or cap staging because they only based on tumor size. I usually don't stage it. Why you stage it as T3 if it's 4 centimeter minimally invasive, right?
Right. So stage and invasion are somewhat disparate, exactly. And so once you start to get to a higher stage, your clinicians start to get worried. Even if it's minimally invasive, right?
Yes.
Right. It's a good question. And I think it's very highly dependent on the comfort level of your clinical team, when they will start treatment and when they won't.
Yeah, because of the term, you already use a minimally invasive, how could it be a T3 tumor? So I just don't stage it, just comment about it, right?
Right.
Yeah. I found out the vascular invasion is the most difficult, and I think because they have more prognostic significant than capsular invasion. But even the publishing, the literature, the vascular invasion, I really like that cap diagram. But a lot of paper publishing actually is easy vascular invasion, even good journals.
Right. Yeah, it's still a controversial area for sure. But I rely on that diagram as well, because I think it's actually quite meaningful, and I can understand how it was derived. Yeah.
Andy may have a question.
Hey, Nicole. Nice to meet you. My name's Andy Nelson. I'm actually a molecular pathologist here with AP training, and I support the solid tumor testing. I actually work and collaborate with Jeremy Siegel at University of Chicago.
Oh, great.
So my question is kind of around subclonal heterogeneity, and what's your thought process and how you do use molecular testing? Thyroid lesions are often very morphologically heterogeneous, as you nicely laid out in your presentation. Sometimes when we're talking about regions where you have a morphologic concern for either papillary morphology, microinvasion, those types of things, that they're relatively small. Are you guys working with the molecular lab there to do either laser capture or very focal macro enrichment of those regions? And I just, as a molecular pathologist working with our folks here, sometimes I worry about the absence of a mutation being used to further support your morphologic impression when we're not quite clear what's, we've got a limited detection around 5%, and is that sufficient to really rule out a BRAF mutation in certain situations and in certain contexts? I was wondering if you could just kind of comment on how you approach that in a multidisciplinary way with your molecular folks.
Yeah, no, that's a great question. So we haven't yet started doing sub-analysis of areas within the same tumor. We sort of tend to focus on the area of highest concern. And so, if we have an area that's very robustly papillary features, I will preferentially, send that slide. That being said, now we don't have testing on the other area, but arguably the other area, at least clinically, is probably going to be less relevant. So we are basically testing the area of highest concern. I completely agree that, the absence of a mutation is not helpful, right? Except if you're dealing with, the absence of a BRAF V600E, you might be able to say, okay, this is not necessarily a conventional papillary carcinoma, but we found BRAF fusions, we found, NTRK fusions. And so I think we found nothing, right? We found absolutely nothing in some benign tumors and even in some carcinomas. And as you know, the new frontier is Hürthle cell. The new frontier is Hürthle cell because it doesn't have the conventional mutations. It has copy number variations. It has mitochondrial DNA mutations. What do you do with that? We're not even testing for that, right? So I think there's a lot to be gained, but I agree that a negative result I sort of regard as not really helpful.
And do you guys, sorry if I missed it when I was kind of going back and forth. Are you guys using the BRAF V600E specific antibody? I know you talked about the RAS one, but I mean, that goes to show that's where having that is worthwhile, because then you can see on a cell by cell, it's like single cell analysis basically, which, you can't do on molecular. And then like you said, I mean, the other way to kind of hedge your bets is if you do find other actionable mutations, then you at least know that you probably have the neoplastic population and what you've tested, and you can start to think about it. But yeah, it gets tricky.
Yeah, it does. And we've only had a few cases where the BRAF was, like you said, like at that really low limit of detection. And by doing the IHC and it's pretty much positive in all cells, like, okay, it's got to be real. Like, it's got to be real.
It's been diluted out in the heterogeneity of the tumor.
Exactly. Exactly.
Cool. Thank you.
Yeah, no, thank you.
Do you do molecular or lymph TTs?
I try to.
Okay.
I try to. So we, it's in one of two ways. So if there was molecular testing done on the FNA, I will rely on that. If there was not molecular testing done on the FNA, then I will sometimes proceed to sequencing of the FFPE. Mm-hmm.
Okay, thank you.
Yeah.
Any more questions? I think it's at 9 o'clock. Dr. Cipriani is going to have a teaching session for residents, so we can stop here. If you have any question, you can email to me or to her. And this is really a great talk about these difficult topics. Yeah, thank you.
Thank you so much.
We'll see you in a minute.